Hello, viewers of this tier YouTube channel by Professor Amdekar and team. This is Dr. Palaniraman, a practicing pediatrician from Tamil Nadu. Today's topic for discussion is localization of facial nerve palsy. As we all know, facial nerve, seventh cranial nerve, is an important cranial nerve responsible for facial expression, emotional expression, and lot of functions. And it is also commonly affected by many pathologies and resulting in both physical and psychological consequences. At the end of this lecture, one should be able to answer three important questions. Does facial nerve palsy present? Is it a UMN or LMN palsy? If LMN palsy, what is the site of the lesion? Before going to the discussion proper, let us dwell upon the anatomy, which is very important. The facial nerve nucleus, facial nerve motor nucleus proper, is present in the lower pons, and it gives rise to the motor root, which travels posteriorly and loops around the sixth nerve nucleus. And before exiting in the pontomedullary junction, it is joined by another important part of the facial nerve, that is nervus intermedius of Winsberg, which has three important components. That is a parasympathetic component or secretomotor functions, mainly supplying the lacrimal salivary glands, and afferent fibers carrying the taste from the anterior two-thirds of the tongue, finally ending in the salivatory nucleus or tractus solitarius, and also somatic sensory from the external ear canal as well as concha, and they also end in the spinal nucleus of the trigeminal nerve. So, both the motor root as well as the nervus intermedius forms the facial nerve bundle. Along with the sixth nerve, they exit the pontomedullary junction near the cerebellopontine angle and travels for a short distance before entering into the internal acoustic meatus, where it is accompanied by eighth cranial nerve. After entering the internal acoustic meatus, there comes the important part where the facial nerve travels, that is the facial canal or fallopian canal, which is a 3 centimeter canal having a zigzag dimensions and are 2 to 3 important landmarks. For example, the facial nerve travels laterally, and when it reaches the anteromedial part of the middle ear, it takes a U-turn around the geniculate ganglia. This is one of the important landmarks. Then it travels horizontally backwards and vertically downwards before exiting the stylomastoid foramen. Before exiting the stylomastoid foramen, it gives a motor branch to the stapedius muscle, which dampens the excessive vibrations of the stapes, preventing hyperacusis. After exiting the stylomastoid foramen, it gives three small branches, motor branches, supplying the various muscles, and finally travels anterolaterally through the substance of the parotid without supplying the parotid, and finally giving the 5 branches of the facial nerve, namely temporal, zygomatic, buccal, mandibular, and cranial, mainly supplying the muscles of the facial expression starting from the forehead to the neck downwards. This is about the motor pathway. What about the sensory and other part? The nervus intermedius, which travels along the facial nerve in the facial canal, when it reaches the geniculate ganglion, it branches a lacrimal nerve, which synapses with the pterygopalatine ganglion and supplies the parasympathetic fibers to the lacrimal gland, nasal gland, and palatine glands. After geniculate ganglion, this sensory part of the facial nerve travels, and beyond the nervous nerve to the stapedius, it gives rise to the nerve to the chorda tympani, which is an important branch, and it contains both the parasympathetic fibers to the salivary glands, as well as it carries the sensory special sensation from the, that is the taste from the anterior two-third of the tongue. So this is the way the facial nerve starts from the nucleus, joins the nervous intermedius, along with the sixth nerve, exits in the pontomedullary junction, along with the eighth nerve, enters the internal acoustic meatus, mainly travels along the facial canal, and in the have made the both the horizontal and the vertical route, comes out of the stylomastoid foramen through the substance of the parotid, and finally branches the thing. What about the supranuclear pathway? The facial nerve nucleus has both two components, a component supplying the upper part of the face, a component supplying the lower part of the face. The component supplying with the upper part of the face is innervated by the corticobulbar fibers from both the cortex, both the ipsilateral and the contralateral cortex, whereas the lower part of the nucleus is innervated only by the contralateral cerebral cortex. Not only there is a motor pathway, there is also an emotional pathway in the supranuclear pathway, which is responsible for the emotions and which supply the facial nerve. For example, in condition like Parkinsonism, this pathway, emotional pathway, is affected, which leads to mask-like faces and with no expressions. Friends, now you should be clear how the supranuclear pathway is there, nucleus and the infranuclear pathway. Now let us go to the localization proper. To start with, let us discuss about the common palsy, that is the Bell's palsy, that is a classical LMN facial palsy which occurs. The Bell's palsy, when it occurs at the level of the stylomastoid foramen, what are the classical findings? The classical findings are loss of the wrinkling in the forehead and widened palpebral fissure, sagging of the lower eyelid, loss of the nasolabial fold, drooling of the saliva and drooping of the mouth. When given commands, one is not able to wrinkle the forehead, not able to close the eyes tightly, not able to blow, not able to smile. When he smiles, there will be deviation of the angle of the mouth to the opposite side. These are the classical signs of facial nerve palsy when the lesion is at the level of the stylomastoid foramen. Further, if the taste is affected, it indicates the lesion is still proximal, that is proximal to the branch of the chorda tympani. Further, if there is hyperacusis, it indicates the lesion is proximal to the nerve to the stapedius. Further, if the lacrimation is also affected, it indicates the lesion is at the level of the geniculate ganglia. Further, proximally, if the internal acoustic meatus is affected, there will be eighth nerve findings in the form of sensorineural deafness, nystagmus, and tinnitus. And in the same way, if the lesion still proximal, if we go to the cerebellopontine angle, if there is a lesion there in the form of tumor, what happens? You will get affection of both the sixth nerve, seventh nerve, and eighth nerve. Further proximal, that is to the origination, when the nucleus is affected in the form of Mobius syndrome, usually it is associated with the sixth nerve palsy. There will be loss of the motor functions, mainly of the motor functions or the facial muscle expressions will be completely lost, but the sensory part will be preserved. These are the ways one can localize the LMN facial palsy. With respect to supranuclear palsy, the common area of affection is by stroke in the internal capsule, where there will be UMN facial palsy on the contralateral side with the contralateral hemiplegia. When it occurs in the pons, when the stroke occurs at the level of the pons, the nucleus is affected, leading to ipsilateral facial nerve palsy along with abducens nerve palsy and the contralateral hemiplegia, which is known as the Millard-Goblet syndrome. So these are the ways you can localize both the UMN as well as the LMN lesions. And further, if there are certain signs like, for example, vesicular lesions and pain in the external ear, you should suspect there is a herpes zoster virus attacking the geniculate ganglia along with the eighth nerve, which is known as the Ramsay-Hunt syndrome. How to differentiate a UMN facial palsy from the LMN facial palsy? It is very easy. UMN facial palsy, first of all, forehead part and eyes are spared because they are bilaterally innervated. Number two, emotional pathway is spared. So whenever there is emotions in the form of laughing, there will be expressions will be present. Number three, there will be long track signs in the form of involvement of the legs and the limbs, upper limbs. Number four, there will be sparing of the taste, tears and hearing will be spared. And the reflexes will be brisk. Whereas in case of LMN palsy, the whole face will be affected. There will be no sparing. Emotions also are affected. No long track signs. There can be hyperacusis, affection of the tears, affection of the taste, affection of the salivation. And there will be unique phenomenon known as Bell's phenomenon. Whenever you close the eyes, there will be uprolling of the eyeballs, which is known as the Bell's phenomenon. And the reflexes will be dull. So these are the ways you will differentiate the upper motor neuron from the lower motor neuron palsy. And finally, most of the time, the Bell's palsy will recover over a period of 2 to 3 months or 3 to 6 months. Sometimes one can go for features of a chronic facial nerve palsy, which is a unique condition. What are the signs? In the site of the affection, there will be unilateral or hemifacial spasms, aggravated nasolabial fold, and crocodile tear syndrome. That is, whenever you chew the food, there will be tears coming in the ipsilateral eye, and reverse Marcus gun winking phenomenon. Whenever you open the jaw, there will be closing of the eyes. These are the unique signs of chronic facial nerve palsy. Friends, hope you are now clear by this time how to localize the lesion, whether it is a UMN palsy or a LMN palsy. In the LMN, what are the where are the sites of the lesion? And finally, what are the signs of chronic facial nerve palsy? Thank you very much. Friends, keep watching the YouTube channel and keep learning. Thank you very much.